So just a few slides, just the why and what of this evaluation of this integrated care program. Well, this diagram represents kind of our vision. So we try to move towards a healthcare system which can learn from research. So take some evidences from research, put them in practice, and then evaluate. So gather data from the healthcare system and then refine and improve this evidence. This is the starting point of our use case for this evaluation, which was an integrated care program for stroke. So we knew from the evidence that patients who experience stroke event and are hospitalized can very much benefit from continued rehabilitation and support after discharge, and this makes a difference in the health outcomes and the amount of activities of daily living that these patients recover. We can see what was the usual care pathway of patients with stroke. So these patients are admitted to the hospital. They stay sometime in the hospital, and then they are discharged to home. We see that in this usual care, at least in our country, this assessment of social needs, of potential social needs, is performed at the very end of the hospitalization process. So just 24 to 48 hours before discharge, the social care teams make this evaluation of social care needs and decide whether this patient needs personal support at home, so housekeeping, or technical support or whatever. So we decided to change, to switch from this scenario to another one in which we anticipated these social care needs. So we decided to start making this evaluation right after admission and anticipate the needs at home and support that these patients will need, and start prescribing and starting all the process of this social support. And all this was supported or was facilitated or enabled by this central electronic health or integrated electronic health record, health social record, that took and gathered data from the healthcare system and from the social care system, which is not provided by the same administration in our country. And I think this is the case of many other countries. Social care is provided by the city council, so by the local administration, which makes sense because most of the times are providing support to citizens and not patients, and is the administration which is closer to the patient. Whereas the healthcare is governed and managed by the country or big area community administration. So we created this common electronic health record so that this evaluation of social care needs could be done at the beginning of the admission. So people, professionals, and everyone was very happy with this integrated care program, but we wanted to evaluate and quantify what were the outcomes or the difference between having this program or not. So we implemented this integrated care program in a few hospitals, and after we got the first 92 patients or the first experience, so we decided to compare the outcomes with people admitted to hospitals not within this integrated care program. We took data from almost or nearly all hospitalizations due to stroke in Catalonia, and we screened these people. We get to finally 1,400 candidates for pairing. So after excluding all people that died there in hospital or were not from Catalonia, so we didn't have data from the primary care setting, etc. And of course, we created a control group pairing, but by some characteristics that are important to compare the outcomes, because of course, the outcomes of stroke patients will vary according to age, according to sex, the comorbidity burden, and most importantly, the type of stroke. So in order for these outcomes to be cleanly compared, we adjusted by these variables, and we took this control group, and we compared the outcomes with the participants in the pilot integrated care program. We can see the percentage of patients in each of the group receiving domiciliary care, so receiving support at home. In red, you can see the percentage or the progression of percentage of patients over time in the integrated care program, and in green in the control group. So as you can see, individuals in the integrated care program were much more likely to receive support at home than patients in the control group. In the next plot, we see a similar progression of this percentage for telecare solutions. So as you can see at the beginning, there are some patients that in the control group that very quickly start to receiving this telecare, but in general, people or patients in the integrated care program are much more likely to receive this service. And finally, at home rehabilitation, which is a key service for these patients to recover the ability to perform activities of daily living. We see here in this plot that not only patients from the care in the integrated care program are more likely to receive at-home rehabilitation than control ones, but we also see that the patients in the control group tend to, at the end of the period, tend to receive as much at-home rehabilitation as patients in the integrated care program, meaning that probably these patients needed this rehabilitation, but there was a delay in receiving this at-home rehabilitation. And finally, in this last slide, we look at first a very hard endpoint, such as mortality, and see whether this integrated care program improved these hard outcomes. And we saw that it wasn't the case. So people attended within the integrated care program had similar mortality rates over time than the control ones. But another outcome that we measured was the admission or institutionalization in a nursing home. And as we see in the plot on the right, individuals entering in this integrated care program were less likely to being admitted in a nursing home, or did it much later than patients in the control group, meaning that probably these patients had recovered more abilities to perform their activities of daily living and therefore more autonomy. And this is important not only from the point of view of the patient who these patients that living at home are probably had higher quality of life, but also from the point of view of the entire system, because admission in a nursing home is quite expensive for the system. So this is also a benefit for the entire healthcare and social care system. So the manuscript is, of course, more exhaustive in reporting these results, but for this webinar, we selected these outcomes to discuss and to showcase this use case. So thank you very much.